for that generous introduction along the way. And I want to thank the Policy Roundtable and Don for the opportunity to be here and share some thoughts at the end of what's been a very rich discussion and very stimulating discussion, and really get to this issue that we're trying to address as what we learn that works and how do we make things happen. So I'm going to make some comments from that perspective of really where the rubber hits the road. How do we take wonderfully stimulating conversations that happen at forums like this and do something with it on the front line perspective? So that's where I'm coming from, as somebody who's been on the front line in communities, working to change and improve health and take programs and spread them and scale them up, as well as representing a lot of our members who are out there doing the same thing. But I will do it from a perspective beyond nutrition. So you've made my job easier in a lot of ways, which I expected, because I'm going to highlight very briefly what I see based on experiences as some key factors when we really want to make things happen. And I think you'll obviously see where I think almost everybody who has already spoken today, I made a little note about, oh, they said something related to this. They've teed up that point along the way. So thank you for making that easier for me. The first thing I want to do, and Dr. Kushner, I know you had the experience of, if you build it, they will come. My perspective when we talk about taking things that work and trying to spread them across the country, scale them up, this is a myth that if you build it, they will come. I would like to change it around and say, if we collectively build it in a community, we will increase the likelihood of people coming for all the reasons that people talked about before. But I think it's really essential when we want to spread and we want to scale that we are inclusive. The concepts of person-centered care are critical here. We need the persons we're trying to serve involved in the design of the implementation. We may be the experts on what works, but we need those people, those patients, to be our experts on how do we implement it so that you will come to it. The community partners we want to work with, the same thing. We need to include them. That takes time, that takes conversations, that takes relationship building, that takes building trust. But it's essential. It's more than buy-in to a concept. It's building the design team that is inclusive of all the parties that we need to figure out logistics related to. We've heard a lot today that we don't have a one-size-fits-all solution, or we shouldn't be thinking that way. The people we're trying to help are a very diverse population. We don't have the magic bullet. So as much as consumers, as much as some of our stakeholders may say, like, there's one thing that we're going to do for the entire population, we know that's not true. And so we have to make sure, as we work in the communities to scale these things, to spread them, that we have different options out there. Different, what I'm calling programs, because it may not be a diabetes prevention program, a Weight Watchers program. It may be this interprofessional, multi-component intensive, therapy that we work together to achieve, but we need options. And even within of those, we've heard a lot today that there are different options within it. There's group, there's individual, there's technology things that have been spoken about. So we need lots of things out there because it's not one thing that's going to do it. There's a lot of things that we have to get right when we do it. And I know in my years in healthcare, I had ingrained in my brain, it's the right care, the right place, the right time. There's a lot more things we have to get right when we want to spread and when we want to scale up. So in addition to those things, and we've heard it today, it's the right approach. It's the right provider, it's the right person, it's the right message. There's lots of things to get right, and I think what our challenge is to think about the matchmaking between all of those things. And as we spread and scale, trying to get all of those things right. It's complex, but it's doable. So the right provider for the right person in the right place, the right approach for them, that language we talked about, the message, and the right time is when is that person ready to access what we have for them. We have a wonderful opportunity to be creative, and we've already seen creativity out there. I think just as much as the people we are trying to help are very diverse, we know we're dealing with communities across the country that are very diverse. That gives us the opportunity to be creative. That gives us the opportunity to spread and scale solutions based on the unique needs of that community that we want to work in. But there are commonalities that I think we need to think about as we think about how do we spread, how do we scale up? Because while we have a diverse country and we deal with access issues that have created disparities and we want to eliminate those things, if we think about some of our mantras of working in the communities, it's the idea of where do people live? Where do they work? Where do they eat? Where do they play? Where do they pray? I would assert, and I'm not going to say every place, but most communities, there are places where those things happen. There are places where somebody goes to school. There are places where people get some kind of connection with the healthcare system along the way. There's a place of worship. There's a place where they get their food. We can bring our approaches into those places. And even the physical activity piece, it doesn't have to be complicated. It doesn't have to be building, a wonderful fitness facility. At the basic level, there's a place in most communities where people can walk. And we can tap into those resources and partner with those groups and address things, spread things, scale them up in creative ways that we do all those things right along the way. I do want to talk about the provider shortage piece because I agree with what's been discussed here. I also want to challenge all of us to think about the provider piece in some additional ways that may be different. And here's where I am going to use nutrition as an example because that's my frame of reference. I hear a lot of the time, and we've heard it here today, there's not enough providers. So from nutrition, there's not enough dietitians out there, so we have to use other people. I think we've also heard about challenges in the payment systems and the delivery systems. So the delivery and payment systems say there's not enough of those people, so we're not going to cover them, or we need to go to someplace else. The providers say, I can't work in that space because the payment system and the delivery system doesn't support it. And so I challenge us, because I think we can break through that, but I think we need to think about how we get through the chicken and egg dilemma and make some things happen. I also think, and this was alluded to, that when we talk about supply and demand, I challenge us to think about a third component to supply and demand that was alluded to. So in my mind, my definition of what's going on is the supply side is the same thing we've talked about. What we say is demand, I think we need to think about as the need. And those numbers are enormous, right? That's the challenge we're thinking about. The demand then is at any point in time, what subset of that population that needs it is really ready to access it. And it's not 100%. I think we all know that. As much as we would like it, it's not 100%. So when we start saying, okay, out of that need, how many people really are going to demand it, maybe that supply-demand equation looks a little bit different and a little bit more manageable, especially as we think about the different approaches that some we know are effective in terms of some people group work, some people individual works. The bottom line message about technology may not be out there, but we have options for delivery that might help to close that gap a little bit more than we may be thinking. I think as well, as much as I sit there and just said, and we've heard, there's so many things to get right, and it's not a one-size-fits-all approach, that at the practical level, when we want to spread these ideas, we want to scale them up, it's all about eating the elephant one bite at a time. And As long as we recognize the bite we're taking is not the end all and be all, and it's not going to solve this universally from day one, we're okay, as we help others understand that as well. So one community, one school, one employer, one payer, one approach to start with. There's so much infrastructure and logistics to figure out. Start with one bite, and then you can expand from there. And my last thing that I think is absolutely critical is we need to maintain integrity as we're spreading and we're scaling things up. As we get creative, as we try to look at the different options and ways of doing things and customizing it for the community, the population we've chosen for the target group, sometimes it's easy when you get the whole group together to be tempted to cut corners on things. Sometimes that can help. You know, we're looking for efficiencies. We're looking for lowering costs. We want to increase the ROI to show the effectiveness. But I caution us, don't throw out all of the elements that are the keys to the success that we know from the great work people are doing out there to sacrifice to save some money along the way. Let's maintain the integrity. Let's use the experts where we need them. Use the trained interventionists where we need them. That type of idea. But let's make sure we stay true to the integrity of what we're trying to accomplish. So with that, very quick, very high level, and I look forward to exploring any of those ideas further in the Q&A section. Thank you.